Humanities. I'm Margaret Mormon from the Center, and I'm pleased to introduce to you today a program that certainly promises to be provocative and even more certainly is both timely and necessary. Improving patient-physician communication about end-of-life care. Is Virginia ready for post? In my first semester of medical school way back in 1969 at the University of Chicago, I observed Elizabeth Kubler-Ross interviewing a 50-year-old high school principal who was dying of lymphoma. It was a unique experience then. It's still a memorable one for me. You notice I remember the details of the person she interviewed. But now, 43 years later, I think it's safe to say that we have all seen more death and dying seminars than any of us can count. We have heard or read talk after article after book about improving communication, about end-of-life care. We have lived or died through developments and promotion of advanced directives. And now we wonder whether advanced directives are really all that they're cracked up to be, not only because still so few people fill them out, but also because it's still too often the case that they're either ignored or too ambiguous to be useful. And we've seen the studies that show how unlikely we doctors are to elicit patient preferences, and when we do, how unwilling we often are to follow them instead of our professional protocols and imperatives. So from Kubler-Ross in '69 to Atul Gawande's now famous New Yorker essay in 2010, Letting Go, we've fretted about how to do it better, but not a whole lot seems to have changed. So today, we're going to hear about and then discuss together a new initiative that seeks to make all of this better, to improve communication and encourage honesty and clarity, and especially to bolster our ability to know and to follow the considered wishes of the patients we care for as they're dying. The POST initiative, Physician Orders for Scope of Treatment, is the topic. And here to explain it to us and lead us into our discussion are some Virginia experts on the POST project. Second, on my right, is Laura Pohl, who's the POST Pilot Project Coordinator, working within the Roanoke Valley Palliative Care Partnership, and to her right, Dr. Christopher Pyle, who's Associate Medical Director of Good Samaritan Hospice in Roanoke, and also the lead physician for the POST project in Virginia. And here to my immediate right is Professor Lois Shepard of our center and of the School of Law, who will respond to their remarks. And then, of course, as always, we'll have time for your questions and comments at the end of the presentation. So, Laura?
Can you hear me? Great. Thank you for this invitation. Thank you for your very thoughtful comments. I didn't even shift the slide and it happened. Okay. So we are really appreciative for this invitation and very honored to be here to look at the question of, is Virginia ready for POST? Maybe I should say briefly about what POST is so you're not left holding the bag. So POST is actually a process that involves advanced care planning, facilitation conversations, where we elicit patients' wishes and values for their care at the end of life. And based on their current medical condition, those wishes are translated into an actionable medical order form. We'll say more about that later. So our objectives today is to describe the need for a system that will ensure respecting patients' preferences at the end of life. We'll review the national POST paradigm. So POST, P-O-L-S-T, is basically the same as what we call POST in Virginia. And we'll review the current regional POST projects in Virginia. Question, you might ask, but my patient has a living will and a medical power of attorney. Isn't that enough? Well, let's look at Mr. Jan. He's a 71-year-old gentleman. He has advanced COPD. He has mild dementia. He was convalescing in a nursing home after he was sent there by a hospital to recover from pneumonia. He developed increasing shortness of breath and decreasing level of consciousness over 24 hours. The nursing facility staff gave the EMS a call, and they found him unresponsive and really having great respiratory difficulty. Now, Mr. Jan had discussed with the nursing home facility staff and his family that he didn't want aggressive life-sustaining measures. He also did not want to be resuscitated. The nursing home staff did not document his preferences, and they did not communicate the do not resuscitate order to the EMS staff. EMS couldn't intubate him. They put an oral airway in, bagged him, and took him to another hospital, not the one that transferred him to the nursing home. He was found to be in marked respiratory acidosis. He was still unresponsive, couldn't tell them what he wanted or didn't want. The emergency room department physician wrote, "Full code for now, status unclear." The staff intubated, sedated him, and transferred him to an ICU. Could this happen in Virginia?
Absolutely.
Does it happen in Virginia? Oh, no. It happens in Roanoke, but I thought we were just like very different from the rest of the state. But so what went wrong? Let me have a few comments on that, a few thoughts.
Lack of clear documentation.
Yeah, so there wasn't documentation of what he wanted.
Was there a physical document from him, and since he was demented, his power of attorney at the nursing home that all the nurses knew about?
The nurses knew about that, but it did not get communicated or documented. Very often what happens in the nursing home, that advance directive document is seen at admissions. Sometimes the admission department keeps a copy, and they also put a copy on the back of the chart. So that was not communicated. So his advance directives were not documented in the record. The DNR order was not communicated in the transfer. There was fragmentation of care, 2 hospitals and a nursing home. He was overtreated, would you agree? Against his wishes, and if we could talk to him, he might say he went through unnecessary pain and suffering. And there was a system-wide failure to respect his wishes. So we didn't plan for contingencies, and there was no system for the transfer of the plan of care. So let me ask you again, in the case of a person with a terminal or serious progressive illness, is having a living will and a durable medical power of attorney enough? No. So conversations before the crisis are conversations that evolve over time. When you're a healthy adult, you name your healthcare agent. You think about, in the case of an emergency or sudden trauma, this is what I would want if I couldn't speak for myself. And you complete a basic advance directive. You really have no idea what's going to happen to you, but just in case, at least I have this much time. If you develop a progressive chronic illness, then it's important to understand what are the potential complications and treatment options. What are the benefits and burdens of end-of-life treatments? You need to discuss your preferences with your family, not just put their name down as your durable medical power of attorney. You dust off that advance directive that you may have written, 20 years ago? And you look and see, is this still what I want? Is the person who I designated as my agent still around and able to make decisions for me? And then reevaluate your goals if your condition changes. Then, in late stage illness, it's no longer hypothetical. We pretty much know what your experience is and what is likely to come down in the next few months. So then people express their preferences for treatment as medical orders. Think of the durable do not resuscitate, but think about the person still has a lot of life to live before they get to the point where they arrest. So this is a point where the post form could be used as a communication tool across care settings and within their setting in communities where it's accepted. And we'll talk about the communities where it is being used in Virginia. So just to sum up a comparison of living will compared to post. Living will is for every adult. In post, the post form is for the seriously ill. For instance, would you be surprised if this patient died within the next year? And if your answer to that is no, then that's a person you would think about having this advanced care planning process put in order. The living will requires decisions about a myriad of future treatments, what might happen, whereas decisions about post come among presented options. The living will requires interpretation. What do they mean by no aggressive life-sustaining treatments? Whereas post is medical orders which turns a patient's wishes into actions. Finally, the living will needs to be retrieved A good question. Where was that living? Where was that advance directive on that patient? Can we even find it? Is it in the lockbox and nobody knows where the key is? Whereas the post form follows the patient across settings of care on a consistent document. Is everyone here familiar with the durable do not resuscitate form, order form? So think about that. So now I'd like to ask Dr. Powell to come up and talk about the way medical advances are shaping the way we need to do end-of-life care.
Thank you, Laura. And thanks for having me here today. And I want to thank everybody for just being here, being present for this talk, especially on such a beautiful fall day. So I really think that it's important to understand how we have evolved into this area of healthcare where we are currently, because I think that has set the stage for why this conversation is so difficult. We've been trying for years now, and it doesn't seem like we're making good progress. Now, I think there's a reason for that. It's not for the lack of trying. So the century of change that has happened, and over the last 100 years, is the cause for why this conversation is so difficult. Because up until the 1900s, and this is throughout human history, again, the average life expectancy was 47. So this is over a millennium. You know, this is what we know. And patients died of sudden events. Infectious disease was the biggest. And you can see heart disease, strokes, and accidents. And patients lived a relatively healthy life until they had this event. But now, through the advances of the amazing medical advances, which really need to be celebrated, the causes of the disease have changed radically. So now, again, still heart disease is number one, but it's not the same as this heart disease. This was an acute myocardial infarction. We have incredible systems now that people survive that, but that 50-year-old survivor of the acute myocardial infarction is now the 90-year-old with end-stage CHF. Cancer, amazing advances. I mean, we get through that primary cancer, but then it's the metastasis to organ systems and then organ system failure from that cancer. So again, amazing advances, but it's changed the way people die of these diseases, COPD and stroke. Again, we have the stroke centers. I mean, it's incredible what we can do now at that acute event, but the patients now have chronic disease and disability. And these chronic conditions have also created decisions that need to be made. So we have to now make new challenges because of the medical advances continue, that's ongoing. And now there's almost a vast array of interventions that we can use during the acute illness to stave off the organ failure from that acute illness. So again, what we are left with is this timeline, and I want to specifically talk about kind of the timeline that most patients now experience at the end of life. It has to do with chronic disease and exacerbations. And as patients go through this, they have these exacerbations over time, and we intervene. And this is a timeline of over years. And almost, again, all disease processes end up in this trajectory because of our advances. And then the interventions, and then they return, but they always don't return to the same level of functionality, but it's a very slow process. So in the patient's experience, they don't always recognize that they're having decline over time. And they get very comfortable with that my CHF is active, I'm going to the hospital, I'll have this intervention, and I will get out, mom will recover from this. And so what is left is that when we have the actual terminal event, it looks the same. This event looks the same as this event. And so it does seem, even though this is a long period, it still seems that death is unusually sudden. And it's happened almost acutely. And because of this, not only does the patients have difficulty predicting, physicians do. As a physician, it's impossible for me to predict this event from this event about how interventions will they be helpful or not. And that's what people are looking for. And if you don't know the patient and their history, it's even more difficult because you don't know the previous hospitalizations. And in our fragmented care system, most patients are meeting their physician for the first time, and each of these exacerbations is not continuum of care. There's not a continuity of one physician or one team of physicians. So again, it makes it very difficult for not only families to know, well, what should we do, but for physicians to guide them. And then the final piece is that this conversation is very complicated because we can talk as a physician about the benefits of this intervention for organ preservation. But organ preservation isn't exactly extending life. There's a difference. And what we need to understand is from the patients what does life extension mean to them. And that comes from their values, their preferences, their wishes. And there's no way I can understand organ systems, I can study that, but I won't learn anything about those without taking the time to discuss and listen to the patients. And they also have to be in a state that they're not acutely ill. It's impossible to have that discussion and get to the meaning of this. So these discussions have to happen before the event, and they have to then move with the patient as they go through the healthcare system. So, and right now we just don't have a system that does that. So what are some of the evolving realities of the incredible change in the last century with advances in healthcare and the current trajectory for end of life? Again, we have this increased prevalence for chronic disease. We have patients with increasing comorbidities. They have multiple organ system failures now because of our advances. And again, we have intervention for each of those. Again, we can help with heart failure. UVA is now an LVAD facility. I mean, we can really facilitate helping preserve that organ function. But then the patient also has renal failure and end-stage respiratory failure and liver failure. So, but we keep offering all these interventions to patients. And this is only going to get more complicated with time. That's a good thing. We need advances. We need to intervene when it's appropriate, and we can restore patients to their previous state of health. But at the end, every patient is going to experience an organ disease, and that's going to lead to death. And we have to be able to give patients an ability, not in the acute setting, but prior, to explain to us what their wishes are. And they need to have the information when it's not acutely happening to them. So what's the end result of this is people they're receiving care that they do not want and for which they cannot benefit. So this is increasing suffering, increasing dependency, and we're getting poor outcomes, or not changing the outcome for that patient. So again, there's a complete dichotomy and a non-alignment of care, and this is what we're ending up with. And they also, on top of that, they fail to receive care they do want. Again, they want symptom relief. They want increased independence, increased functionality. They want to be at home. They want to be surrounded by loved ones. And the current system, unfortunately, all our interventions work against that. Now, the benefit is that if the interventions are successful, we can return them to that. But again, if we can't, then that's their final event. And finally, the biggest thing, I think, is that this concept of that death is optional. What's that leading to? Well, it's leading to a lot of pain and suffering for patients and families and their decision makers. They really feel that because we're waiting to have this discussion after the fact, they feel responsible. Now, we know that because we're medical professionals, we deal with medical ethics, we understand. But when families are in this realm all the time, and it's very difficult. So not only are they experiencing grief, they're experiencing PTSD-like reaction to the death of a loved one. So it really is being very harmful. And we know we can do better. We have, again, this concept of relieving suffering, sitting with a patient, receiving, listening to them, is, we have great data now. That used to be the art of medicine when I was in medical school. And now it's not the art of medicine, it's the science of medicine. We know now that this has improved outcomes, that this is improving quality of care, and patients and families are not only receiving higher quality, they're receiving higher quantity of care. They live longer with this. So we know this, but unfortunately, if we could market that and develop a device or a medicine that would do that, it would be like gangbusters, the outcomes we're getting, but we can't do that. We have to create systems of care. So this is the picture of death in America now. And this is that huge disconnect. So greater than 50% of patients this is their end-of-life experience. We know from study after study that 90% prefer a different environment. But this is what the majority, over 75% of Americans are still dying in institutionalized settings. Okay, so where's that disconnect? And how are we going to change that? And you know, when this picture is you viewed it, and again, we see it, you guys see this all the time. When the discussion comes up, we really get into this situation where, unfortunately, the wording gets confused, and people start talking about, well, we're talking about pulling the plug on grandmother earlier. And my point is that what we need to find out is what grandmother's wishes were. Did she want to be plugged in to begin with? And that we need to get away from this idea of pulling the plug, because again, that's what's so harmful. So here's another case study. There's a miscommunication. So we need to get this right, how important this is. So what does patients mean by that? So again. So post is, again, it's a physician order, so it impacts care. And the only thing that impacts care in America is a physician's order. It can be completed by any provider. So again, we can have other people besides physicians have the conversation and document that, but it only becomes actionable when it's signed by a qualified MD who will then go over it with the patient. It complements but does not replace the bench directions. We still need to do all the other pieces. This is not a substitute. This is just the next step. And there's a voluntary use, and that's real important. It's voluntary, people can choose it, and also the form, as you will go through, you'll see that it's a neutral form. It doesn't just, it's not like a do not resuscitate. All you can pick is one option. Don't do something. It really talks about what we're going to do in place of. So again, it helps us know, because the patient is going to be experiencing care needs at that time. And, the purpose is to provide, communicate patients' preferences for end-of-life treatment is to improve the implementation of the NS directive. When the care is actually delivered, we need some guidance at that time. And again, we want to make sure that there's alignment of care with preferences, values, and wishes. Again, it's for seriously ill patients, terminally ill patients. This is not for everybody. It really needs to be focused on patients that have a real likelihood of using these interventions, and also probably had experience with these interventions. They've probably already been intubated. They've already been on, in an ICU setting. They really know, they have a lot of knowledge about what they are hoping for. So why does it work? Again, it's portable. It contains specifics. And it's a physician order, and again, that physician order and that discussion happens before the acute event, not in the emotional time of the acute event. So what we want to talk now about is, again, where we are with the Virginia Post Collaborative and Laura's work and how it interfaces with the PULSE paradigm.
Thanks, Chris. So Virginia is endeavoring to become what's called an endorsed PULSE state. We want to be endorsed by the National PULSE paradigm and meet certain standards. And so we're developing standardized practices and policies through our pilot project groups. We are training advanced care planning facilitators to have the discussions. We have to have timely discussions in order to that are prompted by a person's prognosis. We have to have a clear, specific form that's actionable and is brightly colored, so it can be easily found among the paperwork. The orders need to be honored throughout the system. We have to do QI activities, which we'll tell you a little bit more about. POST is a system-wide approach. The POST forms can be initiated in any of a number of settings. We find that most of them in Virginia have been initiated in the nursing home, and that tends to be the national experience. But they can be initiated anywhere, and there is a uniform response. So the document indicates specific responses to various likely complications, and we want to avoid getting it wrong. Now here's a map of the various states in the United States that have either endorsed programs. Those are the darker states you see on here. Oregon was the first in 1991. The pink states, of which Virginia is one, are developing programs, and POST is expanding as we speak. Different states have different names for their paradigm. In Virginia, it's POST, POST. It also is that in West Virginia. In Oregon, it's POLST, Physician Orders for Life-Sustaining Treatment. In North Carolina, it's MOST, Medical Orders for Scope of Treatment. But all the forms basically have to have the same elements, and the process needs the same standards. This is our current form in Virginia, which is about to go under revision. because we've had 2 years now with pilot projects to inform us on what needs to be changed. And some of that input has actually come from folks at UVA, which we really appreciate. But just to go through the form a little bit, Section A is about cardiopulmonary resuscitation. And this form has been recognized under our Healthcare Decisions Act as qualifying as an other DNR, other DDNR. So EMS can honor it. It can be honored in the ED as a durable do not resuscitate. But what about all the days, weeks, and months that the person is alive? So a DNR form only tells us what to do when someone arrests. But what about when they still have a pulse and they're breathing? Well, that's where Section B is really very different from most medical order forms that you would see. So when the person is still alive, how do you want us to take care of you? And some may choose comfort measures. Part of that is, do not send me to the hospital unless you can't manage my comfort where I am. When EMS saw this form, when we began planning this, they were just ecstatic because they realized they would be called a lot less to the nursing home, for instance, for people who really probably would want to stay here if they had some clear orders about that. People could choose limited additional interventions. For instance, they might want less invasive airway support like CPAP or BiPAP. Full interventions. Send me to the hospital, put me in the ICU, intubate me, put me on a ventilator. So as you can see, it's a neutral form. They can choose what they want after they have a careful discussion. Section C is about whether or not the person would want antibiotics based on their current medical condition. Section D, I underline the word artificially administered nutrition and hydration, as opposed to we will always offer food and fluids to people in whom that can be safely offered. The front of the form is signed by the physician, and in the next revision, the patient or agent's signature will also appear on the front of the form. Right now, it's on the back. It's also signed by the person who completed the advanced care planning discussion if that person was not the physician signing the form. So we have a number of regional post projects going on in Virginia. The first one started in Roanoke with 1 hospital, 2 skilled nursing facilities, and 3 hospices. And we worked to develop a commonly acceptable post form. This is now where post has expanded in Virginia. So we have 10 areas that are participating in pilot projects, all based on the same standards and training and using the same form. And we expect to have about 3 more areas join us in the next couple of years, at least that many. Is the document enough? I once saw a physician, he told me he handed the post form to a patient's wife and said, go home and fill this out with your husband. This was, I don't know how you got a copy of it, but anyway, this is not a checkoff sheet. This is the last part of a process of advanced care planning and discussions. So we felt like it's really worth an investment in doing careful advanced care planning facilitator training. So in our post-pilot projects, if you're not the patient's physician or DO, then the people who can have these advanced care planning discussions are trained facilitators based on the Respecting Choices model. We've trained over 400 advanced care planning facilitators since 2009. We also have done end-user training with any clinical staff who are likely to come in contact with the form, whether they're EMS and the ED, on the nursing unit, the hospice nurse at home. What does this post form mean and how do you respond to it? So we've trained literally thousands of end users in the last several years. We've conducted a QI project in Roanoke between 2009 and 2011. Most of the advanced care planning discussions and post forms were done in the nursing care facilities in Roanoke. We collected QI data from 100 medical records of people with post forms. Most of the forms were filled out correctly. The post orders were followed as written in almost all cases. We addressed the problem areas immediately. That was a great advantage of doing QI. And the patients and families were very satisfied with the discussion process. Here's some very interesting and compelling data, actually, on the transfer in place of death. We had 9 transfers of people who had postforms between December 2009 and May 2011. And in only one case did one of those patients not come back to the facility. They stayed in the hospital and died. So most of the transfers were appropriate. The comfort couldn't be managed at the nursing home, so they went to the ED, for instance, had a Foley inserted, and then they came back home. Only one patient with a postform died in the hospital. All the rest died at their place of care, their residence of care. And residents who died without a postform, we were actually able to track that in one of the nursing care facilities. And if you died during that period and you didn't have a postform, 25% of those people died in the hospital. So big difference. So that has great implications for hospitals and facilities regarding readmission scrutiny. We have a hospital now that's saying, my goodness, if they work that hard to plan care for people and people are cared for in the appropriate setting, getting the care they want, these are people we would like to partner with. So as far as moving posts into other areas of Virginia, we now have a Virginia Post Collaborative with an executive committee and a statewide advisory committee. We are expecting 3 additional pilot regions to join us. And our ultimate goal of this collaborative is to work with the stakeholders and lawmakers to make posts the standard of practice, to provide consistent and portable form, as well as immunity to those who sign the post form and for those who carry out the orders on the form. The bottom line, and not only across the nation where there are post paradigms, but also in Virginia, we're finding that even in our pilot projects, where communities are agreeing to work with each other, we're bringing nursing homes and hospitals and hospices and home care agencies and primary care practices to the table, and we're achieving the goal of honoring treatment preferences. Plus, this post process serves as a catalyst for conversations. I mean, that is the big thing, and we're not having these conversations now, and now they're happening. This serves as the catalyst. So the take-home message is post provides a better means than advanced directives alone to identify and respect the person's wishes. It will improve end-of-life care throughout the system. Using the form will require communication to make it work in your community. I would like to urge you, if you're interested, to join the Virginia Post Collaborative Statewide Advisory Committee. Lois is on that committee, Cindy's on that advisory committee, and we would love to have more of you join us. And consider UVA participating in the Charlottesville pilot, which is just now getting off the ground. And I'm now going to turn it over to Lois, and then we promise we will not run away, and we will take your questions. All right.
Thank you. Thank you, Laura and Chris, for that great introduction to the POST program in Virginia. And there's certainly a lot to think about here. I'm going to just respond briefly, and then Emma and I are going to go up the aisles and get your questions and comments. First, I'd like to say that I think the POST program appears to really have a lot positive going for it. The gap between advanced directives and doctor's orders has been noted for a long time in the medical literature, in legal cases, probably in experiences that you know about with family and friends, where people thought they had done everything they were supposed to do. They'd done everything we told them to do. And then they discovered that it's not enough, exactly like Laura and Chris were saying. The advanced directive can't be acted upon quickly in the middle of the night when you get the call. So in a sense, I feel like we have, with our whole advanced care apparatus that we've built up over 30 years, that we encouraged patients and surrogates to trust a system that didn't really deliver. And I'm not anti-advanced directive, but we're focusing on this kind of problem here when you have an emergency kind of situation or an acute situation where you have an advance directive and you don't have a doctor's order. And what I mean with that is that we have it delivered both on the medical side or the legal side, right, with the advance directive plan. So I think clearly something has to change, and the POST program seems to be well aimed at that problem. I'm going to mention a few things specifically about the POST program that I think are very positive. And then I'm going to mention just a few things that I think needs some thought and discussion, and I'm sure a lot of people have thought about it a lot more than I do, and so it'll be interesting to hear the comments. But one of the things appealing about the POST program is that it encourages this conversation between patients and healthcare providers to discuss the prognosis of the patient and figure out what might be anticipated, just the kinds of things you were talking about. And it's very different from the advance directive program that started like 30 years ago. Because there, kind of the conception was that you would get these living will forms or advance directive forms in the lawyer's office. We've moved from there, thankfully. It makes much more sense to move it into the healthcare provider's office. So this will help make that happen. And advance directives are often filled out by people alone, who don't know what the treatments are, who don't know what they might expect. And so this is a very different system, which I think is great. Secondly, and this is one thing Chris and Laura also mentioned, was how neutral the program is with respect to things. And this differs also from kind of our advance directive history. Now, things have moved with advance directives, with the living will kinds of forms, where they are now more neutral generally, but it's still quite common to see forms that have kind of an assumption that you're rejecting treatment, right? That you don't want treatment that will prolong the process of dying. There's all this standard form language, and that you want a natural death. And some people do want that. They don't want to prolong the process of dying. But if it's about patient autonomy, then you have to have all the choices, right? And it seems to me that the name POST has that advantage, talking about scope of treatment rather than talking about life-sustaining treatment. That it's very neutral. Another thing I think that's encouraging about the program is that it might help us stop over-interpreting DNRs. There is a tendency among many people, medical providers and others, to think that the DNR means more than it does, to think that it means do not treat, do not intubate, even if there's just respiratory distress instead of respiratory arrest. So the DNR order now is really a very narrow order, which means do not resuscitate in the event of cardiac or respiratory arrest, but it often stands in to mean more. And so if instead we have a form where we have the DNR part or the do resuscitate part, along with these other options, it's not going to be able to stand in for those other treatment decisions. And I think that's a good thing. That's more likely to respect patients' autonomy. The fourth thing that I'd say that I think is very positive is the whole systems approach, because that is a recognition of where we are. So I think that's great. A couple of things that I would just say, going forward that we need to be careful about is the fact we're going back to a form, is that there's, we're trying to use a form, and I'm not saying I have a better option, but we're trying to use a form to solve a problem, and a lot of the problem is communication among providers, right? Because the patient often did her part, or the surrogate, the family did their part, they did the discussion, they might have even filled out the advance directive. So our communication problem is between providers, mostly. So then the question is, how much are we going to burden patients to solve our problem, the communication problem, which is a problem among providers? And so, and relying on the form then carries risks, okay, of burdening patients and families. And some of those risks are inflexibility, with the form. The concern that people's wishes are not truly manifested in the form, or that discussions are not encouraged but become truncated. We worry about with our informed consent forms. They're comprehensive, right? but do they take the place of conversation? And that's one thing that's so great about all the education you're doing. Do things become rote, right, and expected? Again, because we have this form. And will patients and families find the form intimidating? You know, because the first time we were looking at it once in the ethics committee, it was just like, you know, it's kind of overwhelming. And so how do we deal with all those things? I'm not saying they're insurmountable. I'm just saying these are things we have to be careful about as we may be burdening patients and families to solve a problem of communication between providers. So one example of that, briefly, is whether or not there should be a default rule. So on the draft of the form that I looked at, if you didn't check something, one of the A, B, C, or D's, then the assumption was that treatment should be provided. To me, that seems an odd assumption. It seems to me they didn't decide, right? And so that unless it's an emergency situation, there's time to decide. And it seems that if there's time to decide and the patient no longer has capacity, we could get the surrogate decision maker in there and start, you know, educating about prognosis and diagnosis and what the options are. But it's very hard to write forms. I've helped write some advanced directive forms, and it is a huge challenge. So it's something that we'll have to be continually tinkered with to get it right. And then another question I have, and this will be my question as we segue into the question and answer period, is how we deal with the transition where some facilities are using orders and others are not, the post order. So what happens if someone shows up transferred from Martha Jefferson with a post form? What happens then? What do we do? And my concern is we don't have a lot of experience with out-of-facility doctor's orders. We really just have the DNR. And so we're going to be able to expand the trust that is going to be necessary from provider to provider. But the first one had the conversation, did it all right, so that the second one is able to implement it. And the first one's going to have to trust that the second one's going to implement it. And if that doesn't take place, then I fear we're asking patients to trust in a new system, right, that's not going to fulfill their expectations. So that's, I'd love to hear what you guys are doing to, what we do in this transition time. I mean, I think ultimately everybody will be using post, and we'll tinker with the form, and we'll keep doing the education and getting things better and better. But what do we do as we slowly do that? So we'll start with that.
Yeah, great question, and I have an example of how that was addressed. But first of all, setting up in the policies and procedures of a pilot project group, if someone is likely to be transferred to a facility that is not participating, we advise that they go ahead, if that person chooses not to be resuscitated, to also fill out the durable do not resuscitate. We let patients and families know that this form is part of a pilot project and that there might be facilities that are not participating. So that's why we will do a DD&R if that's one of their wishes. The other thing we've done is we've created a letter that accompanies the form. So let's say someone goes from one nursing home to another, and that other nursing home is not participating. And there's a letter that explains to the primary care physician who's going to be taking over the care what the post form is. And also it says on the post form, anytime the person is transferred or their condition changes, the form needs to be reviewed and possibly voided and revised. So we ask the physician to review that and also to let it inform them as to what might be the medical orders that they write in that particular chart for that particular facility. So those are sort of some procedural things we advise. So let's see what happens in reality. So we had a nursing home that where the social worker did an advanced care planning session with a patient and her daughter. The patient has CHF and some issues with renal failure, and the patient chose intermediate interventions. And she ran into some trouble with edema, and the physician wasn't really sure if it was related to CHF or what. So she felt like it was appropriate to send her to the hospital to be evaluated. Well, she went to a hospital that did not participate in the post-pilot, but she also went with a DDNR form, and she did go with her post form. So the patient gets there, and the hospitalist, who was not familiar with the post form, was advising this patient that she needed to be on dialysis. She was like 95 years old. She said, no, I don't want that. And the daughter saying, no, my mother does not want that. And, you know, we had this post discussion, and he's like, what's that? And they were able to translate, forget the post part. This is what I want. This is what I don't want. If this is all you can offer me, please send me back to the nursing home. And the way a post form should evolve over time is if their condition changes. She went back to the nursing home and says, I want comfort measures, not intermediate interventions. I don't want to go to the hospital again. And then they called in hospice, and they put her in a special, one of the palliative care rooms, and she died about 4 weeks later in the nursing facility. So the important piece was what? Was it the form? No. It was a conversation, and them being clear about what they wanted and being able to articulate that, and the social work, we backed them up the whole way. So that is what we have in place at this point. Chris, you want to add anything?
Well, I would disagree, and again, what it does is it empowers that patient and family, because they've had the discussion, and now they feel that they are supported in presenting that, even to a physician, and explaining and feeling like they can express their wishes. So again, that's the power of the conversation.
So now, questions, comments? Here's one.
Hi, thank you for being here. My name is Christy Squires. I am a graduate nursing student here at the School of Nursing in the Clinical Nurse Leader Program, and I am also an EMT certified with the state of Virginia. I like this post form, but when my wheels are turning, and I'm thinking from a leadership perspective, as I emerge as a clinical nurse leader, I want to try to meet society where society is at. And in Mr. Jan's case, in the case study, one more form wouldn't have helped him, because it might have been stuck with the other DNR that didn't get passed on or documented. Are you all at any point considering trying to get this information to like a national database, where if Mr. Jan went to visit his granddaughter out in California for the weekend and he had a CVA, this could be pulled up immediately? Any ideas like that?
Yeah, that's an excellent question. I think when we talk about the communication improvement with the post-pilot projects with patients and families, the other piece that I've noticed over these years of developing these in each community, it finally, again, facilitates discussion between these different entities. It's the only time that we have EMS, long-term care, home care, and hospitals at the table talking about, well, this is how this patient presents to us, this is what it looks like. And again, for our patients, that's seamless from the standpoint of their disease, but for us there's so much dichotomy, so that the communication also improves to improve the system. So there is so much education. I know when the advanced care planning came out, or durable DNR, there was no discussion. It's like, well, the state passed this, here's this law, and here's this new form. And implementation was kind of an afterthought. So we're doing it in reverse. We're really focusing on implementation. And it does improve things, because, again, I think everybody wants to get it right. That's the one thing I see. Everybody is in healthcare for the right reasons. We want to help the patients. But again, this communication improvement really starts to overcome the barriers that technology has brought in the plurality of our society. Now, from the standpoint of standardizing that over settings and using technology, Oregon's been is moving forward with electronic database. They have the EPIC system. They're working with EPIC at that level of how to incorporate this into EPIC. So they're very far advanced. We haven't really gotten there yet, but it's it's being worked on. But when you talk about portability across state lines, then you're getting into a whole other area of reciprocal care. But again, we are working. Those are definitely on the horizon. And again, Oregon fortunately has about almost 30 years of history with this now. And it's an evolutionary process. When we talk about improving the form, they just had a major rewrite of their form this summer. And so it is, and that's the other part of this post project that is so powerful. It's not something that is in the statutes and it's kind of written in stone. Again, it's because it's about providers and communities. It really can evolve, and it can also reflect your specific community values.
And we've had some people come like from North Carolina with their most forms, and we've had conversations saying, we see this form, and then we translate it onto the Virginia form. And North Carolina's been doing the same thing, West Virginia. And we're almost now totally bordered by states that have post-legislated.
Other questions? Well, we're waiting for you to get there. I'm going to let you briefly explain why the language is post instead of post in Virginia. What's the philosophy behind that?
Two reasons. One, because our mentor was West Virginia, and they had post, and also we liked their rationale for doing that. You mentioned it, so you got it. Instead of saying life-sustaining treatment, it's scope of treatment, because it could include any array of options, not just about sustaining life.
I'm Leslie. I'm a resident in the chaplaincy program, and I have a question about, because you're talking about there's going to be training, or there is training for the people who will be facilitating these discussions, and is there in that training, I guess I just want to kind of hear more about the scope of that training, because right now in a lot of institutions and facilities, it's chaplains who are asked to do a lot of the initiating of these conversations, not necessarily because it has to be a religious conversation, which it very often isn't, but because there's a lot of support that needs to happen, emotional support, whatever that looks like. So I'd just like to hear more about that.
Great, Leslie, happy to answer it. So the people who typically attend the advanced care planning facilitator trainings are those whom the institution says are already having these types of discussions. So we get physicians, nurses, social workers, and chaplains are the major groups of folks we see coming to the training. And the Respecting Choices training that we do is a all-day advanced care planning facilitator training, and preceded by a little bit of online study before they come. And those are the only people besides the person's primary care physician who can have an advanced care plan discussion that ends up in a post form being completed.
Right, and the Respecting Choices curriculum is well developed, and it's been substantiated with research that, again, after the discussion, there's high satisfaction for the patients and families, and there's good alignment. And it really, again, helps patients have the discussion with multiple providers. Again, the conversation itself has evolved over time with different facilitators. So, again, and UVA has been involved with Respecting Choices for quite some time. They used to, they have a 3-step process, and you guys have been doing step 1 for probably over a decade of training of, again, how to have advanced directives. And we're step 3. Step 2 is kind of a disease-specific discussion. So they, depending on your disease, like end-stage renal disease, they might train. And then step 3 is this post for patients with advanced disease. So again, there's a foundation of Respecting Choices within this community already.
Gordon Putnam, chaplain in the Cancer Center. Leslie, you will get some training in that
Well, I was
eventually.
just thinking, like, for people who are facilitating this, like in a nursing home or something, maybe not a chaplain who isn't used to doing that's like, or
Like Chris said, we have the training in the community. I just did it. Cindy Wesley, who has been the key person here, and I did a training for social workers in the Cancer Center this morning. All the social workers at UVA have been trained in an abbreviated form in Respecting Choices and having advanced care planning. I did have a question though. Where is this in the legislation of Virginia?
Yeah.
Have you summary of that?
Yeah, okay, let me be discreet.
This doesn't leave the room.
Yes, so our original plan, because our Healthcare Decisions Act is under the legislature, was to go through legislation, which West Virginia did. Over time, the national pulse was saying if you don't have to, try to go with regulation. But we felt like in Virginia, this is probably what we need to do. Then the legislative body that was elected last fall led our advisors to say, let's continue with our pilot projects. What our goal was to have pilot projects, then go to the Joint Commission in the legislature, have them commission a one-year study on post, and then them come with a recommendation, and we have a physician champion, a recommendation to pass it in the legislature. So we are looking at alternatives, which would be regulations like coming from the Department of Health, we already have the DVNR piece of that secure. In Oregon, they do not have legislation, and they've been doing this since '91, and it's working. And the Department of Health came out with a standard that the EMS are to honor. They do not intubate orders that are on the post form. So right now, we're continuing with our pilot projects and building up as many regions as we can who are interested in doing this, and seeing if we can develop the form immunity and portability, uniformity through standards and regulations rather than legislation.
Right, and the key will be that it becomes standard of care. And from a provider standpoint is, again, how you get acceptance and utilization of the form. North Carolina, we were working very closely, they kind of did it in reverse. They got the legislation first, so they have a legislative form, but they had no, and then after they had a form, they had no process for how to disseminate information, how to train, and how to utilize the form, make sure there's some utility to it. And that now that they're doing that process, what they see is they actually want to update the form, but they can't because now it's legislated. It will take that process again. So in a lot of ways, we're still at an advantage because we can update the form through this process, and it needs to have that type of, evolutionary process to it. So I think the jury's still out, but we're certainly, we're in contact with people involved with the legislative process and are getting advised on that constantly.
Well, I think this will probably have to be the final question.
I'm Mary Cummings. I'm a staff nurse here. I've been a nurse for 31 years, and I'm just really grateful to hear this is happening. You know, it's been very near and dear to my heart, end of life care, and my question might be oversimplifying the issue that you actually brought to the table about the form, and I think you partially answered it with the last question. You know, I think I've always found in my career that the inability to locate the form is the issue, you know, and because of making the post a separate form, I can just see that happening again. But I guess my question is, have you noticed the improvement being a physician order instead of just this form? And then the other question is, will they ultimately be compulsory regardless of if a patient has one or not? You know, like, is it a compulsory part of the chart so that we all know that all patients are being given this form, if that makes sense? Because I found that to be the major issue when advanced directives were not being followed. Somehow the form is, you know, yeah, we have one, but I don't know where the heck it is, you know? So.
I'll touch on that and then I'll let you answer the second one about the compulsory. The part about, again, the process and that the form, again, has to be located and there has to be a process. So we have the advanced care planning facilitator training. We have what we call end user training because there's going to be more people that get involved with the form that are actually not going to be developing it with the patient. So we've done that at multiple levels. So we teach EMS, again, this is how you respond to the form. In ED departments, this is how you respond to the form. Within a healthcare system, we developed, you know, online training on the form. It was part of their required training they had to go through. And so, again, so there's, again, a realization of what to do with the form. And so people do take ownership of it by doing it that way. So we certainly have, that's a huge part of that training, that end user training, but it doesn't have to be very involved. It's just raising that awareness. You know, the compulsory part.
Yeah, and we also ask ask where the post form, ask if they have one, ask if they have one, ask if they have one. We put it in a red envelope, says post form in here, please return to Friendship Health and Rehab if it didn't make it back with the patient. We also make a copy on it to keep on the chart. Actually, because copies of the DD&R are now accepted, it's acceptable for a copy to go with the patient. Eventually, when we have electronic, a directory, like in New York, I mean, and in Oregon, they're seeing fewer and fewer physical pieces of paper because it's in the registry, and you can be rest a little more assured that that's the most current one. Is it compulsory? I'm not sure I understand your question, but no one is required to have a post form. We definitely want to steer away. For instance, in some states you're seeing where nursing homes are using it as their default code order status. Some nursing homes are saying we have to have a code order status on the chart. And they're using the post form for that even on their rehab patients. And we're really not wanting that to happen in Virginia, and we want to be proactive in case some nursing homes start doing that. But it's based on somebody's current medical condition, and it's to be used with people who we would not be surprised die within the next year. So we do not want the form to be used for all other sorts of things. It's appropriate for this population, and that the physician and the patient or family agent decide whether or not they want that and it's appropriate. Does that make sense? Mm-hmm.
Thank you. We have to bring this to a close. Two things left to be done, though. First, I want to invite you to next week's Medical Center Hour, which will be Timothy Beatley and Ruben Rainey from our new and really quite innovative Center for Design and Health in our School of Architecture here. They're going to be talking about health by design. Can our built environment make us healthier? And the second thing is, please join me in thanking Laura and Chris and Lois for a really thought-provoking presentation.